Hello, everyone. Welcome to today's webinar, State Medical Boards and Physician Health Programs, Regulation and Rehabilitation in the Digital Age. We are so grateful to have with us two outstanding guests. First up is Micah Matthews, Deputy Executive and Legislative Director at the Washington Medical Commission. And we also have with us today Chris Bundy, who is the Medical Executive Director at the Washington Physicians Health Program. I'm going to turn it over to our first speaker, Micah Matthews. Micah?
Good morning. Thank you for joining us. And by way of background, I've been with the Washington Medical Commission since 2011. I've held this position since 2014, and I participate in numerous industry groups such as Federation of State Medical Boards and the Council on Licensure, Enforcement, Administration, and Regulation. And so I've worked on various telemedicine policies, artificial intelligence, and practitioner health and wellness. So anyway, next slide, please. So our objectives today are, as stated, we're going to get a better understanding of the basics of the licensing process. And we do intend to address some misunderstandings. And just as a housekeeping, if we could have everybody mute their lines while they are observing the presentation, that way we can have minimal disruptions.
Yes.
Specifically, Mr. McMenamin. And then
I'll tell you what, would you mind calling the phone number? I'm actually in a meeting.
Joe, we could hear you. April, can you mute him?
He's muted now.
All right, and so we'll go back to the presentation, and then we'll also discuss the updates and national trends. Some of you may be familiar with this, with the efforts of both the Medical Commission, Federation of State Medical Boards, and the Lorna Breen Foundation. Next slide, please. So just a background about the Medical Commission. We're the full scope regulator for Washington State. We license physicians and physician assistants. We have about 36,000 of them licensed with Washington right now. And so we've got 21 governor appointed members and 64 staff. And what makes the Medical Commission sort of unique, and we just had this confirmed via a external audit, is our commissioners are making directly the licensing and discipline decisions. And so for most licensing decisions that can be made by staff, we have to delegate a certain amount of authority to the staff to do that. And then if there are issues on an application, that actually has to be done and made a decision by the—
I know you like bugs.
And again, if we could have folks mute their lines, we are hearing crosstalk. And so next slide, please. And the next slide, please. All right, so some fundamentals about how we operate. Just so people are clear, hospitals credentials, state medical boards actually issue the license. And when I say the floor standard, what that means is our standards are the minimum to get into a license. And so things like hospital credentialing standards, board certification, above and beyond like AMA, public recognition for CME and excellence, that all is more of accolades and a pile-on, and we do not use those for our licensing standards. Typically, they are set in statute. There are some states whose medical boards have their requirements and rules, which provides them a bit more flexibility, as we learned in the pandemic. And then finally, the destination is medical practice, but with respect to licensing boards, there are several paths to get there, which I'll get to. Next slide, please. There we go. Oh, this has been redesigned. So anyway, we are a paperless body organization, and so we have all online pathways. One is the one that's created by the Department of Health. Another one we use is the Federation of State Medical Boards uniform application. And then if you want to add a third one in there, the medical licensure compact is a online only application. But for the purposes of this presentation, I'm going to be excluding the compact discussion. And so basically you apply online. There's what we call the initial review, which is where we do the intake and see where the application is and where it stands at this point. And then our licensors do a recurring review. So what that means is every 15 days, they, in their queue, they go back and they re-review the application to see if anything has been received that is new that would complete the application. Once they receive everything that they need, they will need to do a final review and send that to the licensing manager, who, if everything is standardized and there's no odd outstanding issues that they're not allowed to approve, then the license will get issued. And so there is some discussion here on the renewals, so we're not going to really touch on the renewals at all. That's just for your information. So the timelines that we typically work with are within the time, once all of the documents and everything that we need are received, we have 14 days to issue that license. So we don't want people waiting around after everything has been received to get that license. We want it out there. On delegated authorities, so as I said, if it's a standard application, then we can issue that as staff without having to escalate it. Things that would escalate a application would be something like a criminal background
Was that
hit,
you?
or a
I was hoping it wasn't Zoe.
or a criminal background hit, or something like a DUI, or perhaps there's a disciplinary action that occurred in another state. So those are what we would call an exception application, and those have to be escalated. They have to be reviewed and approved either by a medical consultant, depending on what the issue is, or it has to go to what we call Panel L. This is a panel of commissioners that are explicit in reviewing only licensing applications. We made that distinction from our disciplinary panels simply because licensing is different, and we wanted to make sure that they were approaching the review of licensing applications from a non-disciplinary mindset, because it simply isn't discipline when we're dealing with those sorts of things. The outcomes of a review from Panel L are going to be either to issue the license with an agreement to practice under conditions, or to order what's called an NRE, or a notice of required evaluation. That's where we may send you to the local PHP for an assessment based off of something that we found in the background, and we want clarification on if it's an issue or not. Sometimes with those assessments, it can result in additional inpatient treatment, or it can result in a clearance, and then we move on and just issue the license. And then finally, it can result in a denial. Just for everyone's clarification, denials based off of lack of qualifications or not meeting the qualifications are not reportable to the National Practitioner Data Bank. All other denials are. So if we deny based off of disciplinary action in another state, then that's going to be reported to the National Practitioner Data Bank. So with respect to the non-routine applications, so we talked about criminal justice, really the ones that we see in physician and physician assistant licensing tend to be DUIs. And so we have a sort of an unwritten rule that if it's less than 3 years old, we're probably going to send you to WPHP for some kind of an evaluation. If it's over 3 years old and it's only one, we're probably going to give you a pass and just give the license. Qualifications, that's set in, as I said, set in statute. And so we don't really get a discretionary decision on that. If you don't meet them, you don't meet them, and that's it. The one exception to that is for IMGs, and this is, international medical graduates. And this is something that's fairly new for us. There's something called an exceptional waiver. And in 3 categories, you can prove your ability to have certain requirements waived that we have in rules. So that's mostly about 24 consecutive months in GME. You would still have to have GME at this point. We're looking into revising that requirement, but if you have exceptional work in publishing, employment, or academia, then you have the ability to submit as an international medical graduate to have a waiver of certain requirements. And then finally, PHP issues. So if we get someone coming from another state who has been involved in their PHP, or if we have someone who has, as I mentioned, the DUI or substance abuse issues, we will likely refer them to WPHP to have an assessment and follow whatever guidelines that they recommend. Next slide, please. So we're going to jump right to myth busting. So we have on occasion heard folks saying that state medical boards don't want people to seek treatment. That's just simply false. We want you to seek treatment. We also recognize that physicians are not always the best patients, and that may be a stereotype, but it's a pretty accurate one in my experience, just personally and professionally. And so we fully support and want you to seek your own treatment. And leading to the next one, state medical boards do not, in fact, know when you're getting mental health, physical, or substance abuse treatment. Specifically, substance abuse treatment has a very high federal confidentiality standard. So we're likely not going to know much about it unless we reported you to the WPHP or referred you to the WPHP. And even then, it requires signing waivers to share information. We don't, at the Washington Medical Commission, we don't have access to everyone's patient records. We don't have the ability to go and dig in and figure out who's getting mental health treatment or not. That's false. We don't have that ability. And finally, this is probably more of a recent thing for some medical boards. We've had this in place for more than a few years, and along with 23 other medical boards, and that is we don't want to know about your mental health issues or your physical issues. That's why we have converted to an attestation model on our application, to where you simply acknowledge that if you have any issues that need monitoring, if you have any health issues, mental or physical, then you need to be known to WPHP if it's something that you can't handle yourself. We put that responsibility on the licensee to know that what the line there is for reporting to WPHP or getting monitoring, getting treatment on their own. And so we also reduced our substance abuse question to define active substance abuse as something that had happened in the last 6 months. And so again, that's a attestation model that is becoming more common nationally, and we're encouraged to see that. And as we showed in an earlier slide, we did win a accolade from the Lorna Breen Foundation for having non-discriminatory questions on our application. So when do we know? Well, as everyone knows, there is a mandatory reporting requirement, especially among the mental health treatment folks, when someone is a danger to themselves or others. That's a legal standard that everyone has to apply. And so we do get reports when someone is threatening self-harm or harming others. Usually we try and intervene with those with WPHP's cooperation to try and have a therapeutic resolution, and preferably one that's pretty confidential. Employers will send notice to us when they have concerns about their practitioners. Usually in Washington State, my understanding is that most of the employers send folks to WPHP for an evaluation first, and depending on the cooperation level and what is found, will usually not be involved, which is our preference for these things. Frankly, state medical boards are not well set up to deal with medical, mental, or substance abuse issues, and that's really why we prefer that. And then finally, PHPs. Sometimes there's just not a great option, or with respect to someone getting involved in PHP and they are non-cooperative, or they just simply cannot maintain. And at that point, WPHP has a responsibility to report that to us, and we would have to get involved. Usually the outcome of that is either mandating them to cooperate with the PHP, or there's a suspension when things just simply go off the rails and they are not capable of practicing medicine due to, usually it's a mental health issue that goes pretty wrong. So anyway, next slide, please. So the recent changes that I was mentioning, we did undergo a full review to try and find any implicit bias issues. And so the result of that was no longer mandating a picture to submit in their application. We never used it. It only came out when something went hit the news media, and then we got a public disclosure request where we had to release it. We also altered the questions as mentioned. We reduced the amount of time that we ask for in your chronology. And I'm not entirely certain even at this point that a chronology is absolutely necessary with respect to an application. So we only ask for the last 7 years at this point. The big one I think that has really streamlined our processes is the reduction of reliance on the applicant or say GME program. So the old model was you would apply, you would get this document, you would have to send to your GME program, the program director would have to complete it and send it to us. That was a lot of delay. And we were able to get more detail faster from a more trustworthy source by way of the AMA and the Federation of State Medical Boards. Both have databases that we can query. And so those are both credentialed CBOs that are allowed to be represented as primary source. In the case of FSMB, they are accredited by NCQA. And so we felt comfortable no longer relying on the applicant information and querying those databases. It sped up quite a bit and eliminated all of the mail time that we had to deal with. And then finally, the personal data questions, which I mentioned, we reduced the time, we went to the attestation model, and we also clarified that there's a safe haven in the form of WPHP. If you're known to them, we don't want to know about whatever issues that you may have. And so that's, as I said, 23 states and counting are changing over to that. Next slide, please. And that's the end of my presentation. Thank you.
Good morning,
Wonderful.
Chris. Are you ready for me?
Yes, thank you, Chris. I was just
Am I
about to.
sharing?
Yes, you are.
Okay, perfect. Good morning, I'm Chris Bundy. I am, as mentioned, the Executive Medical Director of the Washington Physicians Health Program, and it is a proud pleasure and a privilege to be here with you today. I'm going to follow up Micah's presentation on regulation with some more information about physician health programs. And with all of the things that people do and don't know about regulators, there's even, I think, less known and perhaps more misinformation about physician health programs. This year, we are really celebrating 50 years since the seminal article in the Journal of the American Medical Association, 1973, called The Sick Physician, identified a need for the healthcare community to provide support and assistance and a therapeutic option for physicians and other health professionals when they fell ill, that doctors have no special protection when it comes to the kinds of conditions that can impair safe practice and may indeed have some vulnerabilities, including a reluctance to seek help when they're not doing well. So our goal is to help you understand a little bit more about how 50 years ago that evolved into the model that we have today across most states. Now we have 47 states with a physician health program. A couple have more than one physician health program. So there's probably a physician health program near you. They're not all the same. Some of them are different. Most of them are actually independent nonprofits that spun out of their medical association, their state medical association at some point along the evolutionary pathway. Ours spun out. We started as a committee in the Washington State Medical Association in 1974 and spun out as an independent nonprofit in 1986 and have been operating as a physician-led 501c3 organization since then. So while programs may differ in structure and funding and so forth, I'm going to talk about my program in particular, which really checks all the boxes when you look at the Federation of State Physician Health Programs guidelines for physician health programs, and the AMA model legislation that exists that describes the model program. I'm not taking credit for that. I inherited the program 10 years ago from the people who came before me that were wise in terms of how they built out the enabling statutes and curated the relationships in Washington that allow us to function in this way and to be sufficiently funded to meet our mission through a license surcharge that all potential beneficiaries in Washington state for our services pay. We serve physicians and PAs, dentists, podiatric physicians, and veterinarians in Washington. First thing to know is that physician health programs are voluntary, which means that we can't actually take any adverse action against somebody referred to us. Typically, the referrals are externally motivated by employers or credentialing entities, at least initially. And then we try to bring the participant along to be internally motivated to participate in the program. We have about 10 to 15% of individuals that are true self-referrals to the program, not being referred by a workplace or by a medical school or graduate medical education program. We do serve students and residents of the professions that I mentioned just a moment ago. We also get referrals from attorneys and care providers of the health professionals we serve. So a wide variety of referral sources, but oftentimes under some sort of condition of duress. Things aren't going well in the workplace. The individual may have just gotten into some legal issues and an attorney has referred them to us. Family or friends have expressed some concerns and attached some consequences to participation. Our PHP is extraordinarily confidential. 90% of our program participants are never known to the medical regulator. So Micah, who just presented, doesn't know most of our participants. Those that are known are usually known because either through the course of an investigation or discipline by the regulator, it became a concern that they might have an impairing health condition, and so they were referred to us. And then usually around 2 to 5% of folks that we are involved with in a given year are simply unable to work collaboratively with us. And in those cases, when they represent a risk to patient safety, we have no choice but to exercise our mandatory reporting obligation to the regulator. We are therapeutics. Our goal is to get people into the care that we know that works for mental health and substance use conditions, and we're highly effective in doing that. We provide accountability, and we are accountable. We're accountable to the licensees that we serve. We're accountable to the State Medical Association through a continuing governance relationship with them. We have accountability to the referents, the healthcare providers and organizations that we work with, which I'll say a little bit more about later. We're trusted. We're the trusted verifier of safe practice. So when an employer or credentialing entity or the medical board refers somebody to WPHP, and we give them a green light, and it really is green light. We don't go into details about what the diagnosis is, what the treatment plan is. We don't provide that information. We provide a statement that this individual is verified as being safe to practice. And because we've been doing this for 40 years in our state, those entities that have a need to know that this individual is safe trust us to do that. And 95% of program graduates report needing and benefiting from that advocacy that we provide for them. It's a peer-based program, so it's doctors helping other doctors, utilizing expertise in the area of mental health and substance use disorders. I'm a psychiatrist by training, adult and geriatric psychiatry, and I'm also board certified in addiction medicine. My colleague, Dr. Laura Moss, is an addiction psychiatrist as well. And we are objective. So we provide objectivity, and we use evaluators and treatment providers to increase that objectivity within the program, and comprehensive. We look at all aspects of health so that we can help people have careers and lives that they wouldn't have imagined possible before coming to us. Nonetheless, our role is uneasy. People who are coming to us are often having the worst day of their life. They're not happy to be with WPHP. Nobody wants to be identified as needing our services. And where somebody in somebody's experience and our experience with that individual is largely going to be determined on the temperature of the water. Because we're dealing with people at best who are unwell, at worst unsafe, and depending on where they fall in that spectrum is going to determine how much How much of this is really voluntary feeling to them versus other directed and compulsory in terms of what kinds of evaluation treatment are needed to credibly verify that they are safe to practice. Our process is a case management model. So an individual is referred to WPHP, they are assigned a case manager. That case manager partners with them to get them through the process. And the process is, of course, difficult in the beginning. There's a lot of questions and uncertainty, a lot of things that need to happen in order to get through the initial assessment to find out whether, one, can that individual continue to practice while we continue evaluation and treatment, or does that individual need to step out of practice, take a medical leave while we do evaluation treatment. All of the things in parentheses here where it says PHP are the things that the PHP does in-house. But if we can't rule out an impairing condition, and in probably 40% of people that are referred to us, about 60% of people that are referred to us, we rule out impairment. They don't need to have ongoing involvement with the PHP. And one of the myths I'll get to later is that people believe that if they're referred to the PHP, that they're kind of being railroaded into a program. The data just actually doesn't support that. I mean, we help people way upstream of impairment without enrolling them in monitoring agreements. And part of the way that we make sure that we have integrity with that process is having independent evaluators make the decision about, one, what is the diagnosis? Two, what treatment is needed, if any? And three, is monitoring needed? But if monitoring is needed, we provide that for the participants. There are lots of barriers to PHP utilization in health professional populations. And I don't think that these barriers are particularly unique to the PHP, although there are things that we're doing on the advocacy front to try to reduce these barriers. The stigma of mental health and substance use disorders is alive and well in the House of Medicine, as is the culture of silence and the difficulty with which physicians have in asking for help or being vulnerable. They are still held to unrealistic expectations of competence and perfection that get in the way of acknowledging and seeking help, or even wanting to look like they need help amongst their peers and colleagues. There's a lack of awareness about what PHPs do and how we can help, what services and support is available. In addition to just a general lack of awareness, there's mis and disinformation. There are people who we have worked with who have been too sick to benefit from our involvement. They've been too sick to maintain a medical license. They have lost their medical license due to due process within the licensing process. And those individuals get angry and they spread misinformation. And we will not violate confidentiality to defend ourselves. All we will do is put out information that we believe tells an accurate story about who we are and what we do, and let individuals make their own decisions about whether they want to work with us or not. We are often confused with the state medical board. And while we are heralded as a program that has a mature, long-standing relationship with the medical board that I think benefits our participants and those who are involved in discipline, sometimes that creates confusion, that collaboration. There are real and perceived burdens of participation. Some of the burdens are made up and not real, and we can help people kind of work through those. Some of those are real. Financial burdens of participation, not so much related to the PHP, but the quality and expertise of the external evaluation for safety-sensitive healthcare workers. That's a specialized field, and so we have to approve the evaluators and the treatment programs that our physicians and other health professionals use in order to credibly advocate for their return to practice, and those come at a cost that is unfairly, I think, and disproportionately borne on the backs of the participant. And I am advocating, as along with others in the Federation, state physician health programs, to change that. And then I think organizations in general sometimes have a lack of clear policies and procedures about when a referral to the PHP ought to be made. And so I think when we do work with organizations to kind of look at their policies and procedures, if a physician is having difficulty, if there are performance issues, when is the Goldilocks and the Three Bears time when the porridge is just right to make a referral to WPHP. We don't want to be referring everyone to WPHP who's having a bad day, but we also don't want to let things get so bad that they're really on their last chance by the time they get to us, because we can and do help people turn things around. Many myths and misunderstandings. I'm going to go through these as quickly as I can just to get them on the table. The PHP is punitive. I don't think that we're punitive. I'd have a hard time getting out of bed every day if I thought that we were punitive. But I get why people can feel that way. We ask a lot to get the outcomes that we get, and in terms of substance use disorders, 80 to 85% of our folks are substance free at 5 years, which if you're housed and employed, in the general population, you're going to return to use within 6 months in 50% of cases. So the statistics are not good for the general population, however, they're excellent for physicians. And there's comparable data for mental health issues as well. And so what people want to do to get better isn't always what they need to do to get better. And so that can feel punitive when we are directing what needs to happen. But as I mentioned, we have no authority to take adverse professional or licensure action against a participant. So the idea that we are the ones that are being punitive or holding individuals accountable for consequences is false. The PHP is coercive is another myth. Again, we're voluntary programs. There may be external motivators to engage. And as one wise person once said, just because you don't like your choices doesn't mean that you don't have choices. Philip Candelas, who's a medical ethicist, has written on this topic of coercion. And one, if it is coercion, it does actually work. We know this because coerced treatment in the criminal justice system works. But if it's not coercive, which Philip argues that it's not, it's a function of the social contract with physicians and society, then coercion is not an applicable concept to physicians in this situation. Some people think that physician health programs only are for addiction, but the vast majority of physician health programs today address any potentially impairing health condition, including burnout and other causes of professional distress. So we're really trying to cover the waterfront of things that physicians might be experiencing, other health professionals might be experiencing. Again, the PHP is a state medical board, or not truly confidential. Some people might think that we're secretly having conversations with the state medical board. First of all, we don't have any conversations with the medical board without consent. And if we knew that we needed to have a conversation, I usually talk with my participant about what that conversation is going to include. Except for a few cases, the PHP is independent from the medical board. The medical board programs that I'm aware of are firewalled in terms of confidentiality from the state medical board. So I think there really is sensitivity to communications that are going forward. And as I mentioned, mine, like many programs in the country, 90% plus of our participants are unknown to the licensing board, completely confidential from the board. And we have you have the ability to refer concerns for impairment in Washington to us in lieu of a mandated reporting obligation of the licensing board. I think that's one of those key statutory building blocks of a PHP, if you will, to provide that therapeutic alternative to discipline so that people can discharge concerns for impairment by contacting us rather than the medical board. I hear a lot of the PHP is a racket. Again, this idea that if you're referred to the PHP, we're going to be motivated to enroll you in a monitoring agreement and give you a diagnosis that you don't have. I actually say that the deck is stacked against us with regard to diagnosing conditions that people are motivated to avoid having diagnosed in themselves. Again, I mentioned physicians are not help seekers, and the prospect of being discovered for having a mental health or substance use problem often motivates them to tell their story and to provide a narrative that isn't consistent with a substance use disorder. So really, I think our work is cut out for us in terms of trying to understand what might be going on that can be affecting somebody's practice. And as I mentioned, we don't make our own evaluations. We use independent evaluators, and there's a lot of, I don't know, speculation or allegation out there. There has been, at least at times, that there's some financial arrangement between PHPs and evaluation treatment providers to make this all work, according to this kind of racketeering allegation. It's just not so. That's all I can really say about that. We do things like give participants a choice of evaluators, treatment providers, let them know that they don't have to get treatment at the same center that did their evaluation. Things that we can do to help preserve a sense of autonomy and choice in the process. PHP is costly. It's not really the the PHP that's costly, but I think the appropriate care, as I mentioned, and time away from work is not sufficiently supported by the healthcare system that benefits from the work that health professionals do. We wrote a paper on this, financial barriers to recovery, last year with some folks from Harvard. And it really underscores what's needed from the healthcare system to overcome these barriers. It should not be borne on the backs of the sufferer. PHPs actually operate under a microscope of accountability for all the reasons I said earlier. We've got credentialing entities in hospitals, wanting to be in our business about how we're doing, what we're doing, what's our process. Are we making reasonable decisions about these folks when they're complaining to the hospital and credentialing entity that we're being mean to them? Same with the state regulator, same with the state medical association. We really are regularly called upon to, not in individual cases, violate confidentiality and discuss decision making, but to really have clear transparency, accountability, and excellence with regard to our practice. PHP will ruin my career. A lot of docs feel like if they go to the PHP, their careers are over. My experience is that their careers are just beginning in many respects. How do we support telehealth? Well, first of all, we do most of our work now since the pandemic. I think most PHPs are doing the bulk of their work via telehealth. So we're really in this space, and we really understand the challenges of providing service. We operate across our state, so oftentimes a wide geographical area that better serves our participants. It's less costly and inconvenient for people to participate in the activities of WPHP, including their weekly monitoring groups and meetings with their case managers, when they can do so through telehealth. We've also led really nationally on the development and implementation of remote or home-based toxicology testing, which is really, a game changer in terms of how toxicology testing has been done for the last several decades. This again improves user experience with the program and allows us to have a robust testing methodology that isn't as interfering with the time of with the many busy schedules of the folks that we're working with. We have agreements with other physician health programs. So when a practitioner is sitting in Washington providing telehealth across state lines, we can be in communication with the physician health program in that state to discern from them what would be the requirements. Are there any concerns? Does the medical board in that state need to know? Generally speaking, we work collaboratively in the PHP world to minimize the burdens to the participant, while also not getting sideways of any regulatory issues. But I will tell you that this is a new and evolving area, and I think that as long as we're oriented towards, both, again, as we've always done, finding that middle ground between protecting the public and making sure that nothing we're doing is putting the public at risk, but also minimizing the burden to the participants so that they can practice telehealth without undue burden, without needing to be involved in every PHP in every state that they're involved with. We aim to that end. And then I think that there continues to be challenges for the telehealth professional. If somebody's 100% telehealth and they're working out of their home and they don't regularly interact with other people as they would in a physical workspace, it can be hard to have meaningful workplace monitoring, which is one of the cornerstones of the work that we do, is having one individual in the workplace who can alert us to any behavioral changes that might indicate recurrence of illness. Determining the applicable monitoring program. As I mentioned, where a professional sits versus where the patients are receiving care, we have to sometimes have discussions about what makes the most sense in terms of who the primary monitoring program is going to be. It isn't the case usually that somebody needs to be involved with multiple monitoring programs as a primary, but we do have memoranda of agreement so that we can at least provide compliance correspondence to those other monitoring programs who need to have awareness of the individual safety to practice based on telehealth services that they're providing in their jurisdictions. And then the regulatory interface when involved in discipline across multiple jurisdictions. So as I mentioned, most of our folks, the vast majority, are not discipline involved, but when they are discipline involved, and then that discipline tracks across multiple jurisdictions, one license action in one state translating to multiple license actions in multiple states, then we might have to be working with each PHP and each regulator independently to help unwind those problems and rehabilitate back to practice. And that concludes my comments, and I think we are at the point where we are open to questions. Or comments. I see my buddy Joe Jordan is on here from the North Carolina Professionals Program. Joe, did I get anything right, or did I miss something that you think is important?
Well, I think I just got voluntold to make some comments, which I really appreciate, Chris. I would say, first of all, I think you did a wonderful job of explaining the challenges of working in the arena of kind of not co-regulating, but the regulatory boards have certainly a challenging environment in which to work, and PHPs do as well. I would echo your comments about there being some misperceptions that the numbers don't really bear out. For example, the idea that if someone comes to PHP, they're going to be immediately shuttled off to to some place, when in fact, similarly to your experience here in North Carolina, probably 30 to 35% of the people that are referred here due to an incident. And what's interesting, as Chris said, is each PHP is kind of different than others. We also are an outgrowth from the Medical Society in 1989 and are now a 501c3. But probably I would say that 60% of our referrals are from the medical board that has utilized our program here to facilitate the rehabilitation and return to healthy practice of physicians and PAs and perfusionists. And we're also working with the pharmacy board here in North Carolina, as well as the veterinary medical board and the PT board. So, our goal here is to really advocate on behalf of persons that have treatable illnesses that, are somewhat stigmatized in our culture. And therefore, we want to make sure they get a fair, equitable, and understanding process for their, being able to practice and being able to practice without stigma or prejudice against persons with these conditions. I really see my role here at PHP as promoting understanding and decreasing stigma. We have a nation of individuals, and here in North Carolina, and I know that, well, I don't want to speak for Washington, but I feel that, having heard Chris speak on occasion, he too feels passionately about helping individuals who might not otherwise get a fair shake, get one in front of boards and regulatory agencies. That being said, I do want to give a shout out to the North Carolina Medical Board as being extremely supportive and understanding of persons that have addictive disorders, mental health issues, and other conditions that may, if left untreated, render them unable to practice safely. I have consistently been impressed at their willingness to work with persons that they have referred to us, even to the point of creating a grant fund that is supported by voluntary contributions that allows NCPHP to provide grants to persons that are receiving outpatient, inpatient, or evaluation processes. And Chris is being a little humble, Mr. Matthews. I would just say that Washington State is lucky to have one that is someone as dedicated as Chris is. He is constantly and eloquently out extolling the model of physician health programs. And I'm a little embarrassed to be on the same panel with him at this point, but hey, I'm working towards it.
We do appreciate Chris's role here in Washington. One thing that I think is fairly unique with respect to how our process works is when someone goes through the disciplinary process as part of the compliance rehabilitation, we have them do personal appearances where they come before the actual board members as a panel, the ones that actually were familiar with the case and made the authorizing charging decision, if there was one, and they come before them to attest to their compliance, and they have a conversation about how things are going. The board finds value in this for a number of reasons. Not number one is the whites of the eyes thing seems to provide a better accountability than in a lot of settings. But with respect to PHP candidates, Chris comes and is an advocate for them, and he's a trusted, reliable source to tell us that they are on the path to recovery. They are compliant with monitoring, and it really is a great reassurance to our folks to hear that from someone such as Chris, who is an expert, who is our partner in this, whose mutual goal is to get these folks rehabilitated and back to safe practice.
That's we do similar appearances for the medical board here in North Carolina, and this morning I was at the pharmacy board helping 3 pharmacists regain their license through an administrative hearing process, and it's an opportunity for me to see the work that they do. I'll just make some suggestions as Chris spoke about. We don't have any regulatory authority at NCPHP. We are a voluntary organization for individuals that choose to utilize our services. But later this week, I will have the pleasure of appearing over at the medical board to help 2 physicians regain, hopefully, and we believe they will regain their license to practice medicine. And it's one of the more pleasurable parts of my job, if not the most.
And I think I'll just, from the medical board perspective, point out that why PHPs are so important. Chris sort of hit on this, but the statutory language for Washington, and I think it's probably similar to North Carolina as well as others, is it's the statutorily authorized therapeutic alternative. And that's an important statute, because bottom line, medical boards are simply not set up to deal with what PHPs are. So you have to understand that if that's the alternative and we don't have that, we don't have the ability to do an assessment in-house. We don't have an ability to do inpatient treatment or anything else like that. There's some statutory questions about whether we can mandate someone into a private treatment center. And so what our options are, if you take all that away as a medical board, is either some sort of proof in-house, which would probably just be testing, that you are able to practice with reasonable skill and safety, which again, we don't have the ability to assess that in certain situations. And so our alternatives left are frankly indefinite suspension or revocation. That's the way we would be able to deal with mental substance abuse, physical issues. And that's not the way we want to approach that. That's not a human-centered approach. That's not a rehabilitative approach. And so that is why the partnership between state medical boards and PHPs are so important, because they provide that human-centered approach that allow us to maintain what is frankly a very expensive profession to train and keep them in the workforce benefiting our citizens and our patients, so long as they're within that safety realm.
Yeah, I think as we're kind of getting towards the end of the time, I understand CTEL to be really primarily an advocacy organization, and I would say that, you know, the take-home message here is we're willing to partner with anybody on advocacy issues that benefit the profession and benefit patients. And, you know, we know that it's a bit of the Wild West as telehealth is, you know, swept across the country in the wake of the pandemic, and trying to figure these things out, but ultimately getting out of the way of good doctors trying to take good care of patients in need. And I think we're all aligned to that mission. So just keep us in mind, you know, as you go about your work. Know that we are willing partners, and for a moment, you know, I'm here representing the Washington Physicians Health Program. Joe and I both sit on the board of directors for the Federation of State Physician Health Programs, and I know the Federation is always up for partnerships in ways that we can be helpful and collaborative. So I'll end with those comments.
Ditto.
All right, last call for questions or comments. Hearing none, I think we'll turn it back over to CTEL. All right, thank you, everybody. Have a good day.
Take care. Bye-bye. Thanks for coming.